Hello, everyone. I'm Patricia Koffman, the co-founder and communications director of the CLL Society. Welcome to our 7th COVID-19 webinar titled COVID-19, Are Monoclonal Antibodies What the CLL Community Has Been Waiting For? Today, Dr. Shahzad Mustafa will present background information on immunodeficiency, proposed evaluation of immunodeficiency, as well as share important breakthroughs in the development of monoclonal antibodies for both prophylactic and post-exposure use against COVID-19. If you've missed any of our past COVID-19 virtual community meetings, you can find them on our website on the COVID-19 updates page or on our on-demand education page. We would like to thank Adaptive Biotechnologies, Pharmacyclics, Janssen, Bristol Myers Squibb, and Regeneron for supporting today's webinar. At this time, I would like to introduce our moderator, Dr. Brian Koffman, Executive Vice President and Chief Medical Officer of the CLL Society.
Thank you, Patty. I'm Dr. Brian Koffman, Executive Vice President and Chief Medical Officer of the CLL Society, and I'd like to welcome our audience and speaker to today's events. I'll be getting things going by giving a brief introduction about the risks of getting infected with COVID-19 and a little bit about our impaired response to the infection itself and to vaccines. Next, we'll welcome Dr. Mustafa. Dr. Mustafa is an immunologist and lead physician of allergy, immunology, and rheumatology with Rochester Regional Health Clinical and associate professor of medicine at the University of Rochester School of Medicine and Dentistry. He is also a member of the CLL Society's Expert Medical Council and has done extensive research on the immunocompromised states in CLL and other blood cancers. Dr. Mustafa will provide background on how CLL and SLL patients are immunocompromised and updates on what we've all been hearing a lot about, monoclonal antibodies, how they work, their benefits for CLL, SLL patients who might have a suboptimal response to the COVID-19 vaccines. And lastly, we'll welcome back Robyn Brumble, who's the CLL Society's Director of Scientific Affairs, and our very own registered nurse who will share CLL Society's COVID-19 action plan, which we highly recommend that you complete and save before you actually need it. And we'll begin with my presentation. I'm going to start our experience today learning about the immune system and how to tweak it and make it better during the pandemic by explaining some ways we can understand and minimize our risks. And notice I'm not saying eliminate our risks, but minimize our risks. We've all known that CLL, SLL is a cancer of the immune system. It's a cancer of the B cells, and B cells are what make antibodies. And therefore, it's not surprising that our ability to make antibodies is diminished, and our response to infections, all infections, including COVID-19, is impaired. But this was largely an ignored problem until the present pandemic. I remember hearing an interview with Father Gregory Boyles. And for those of you who don't know Father Gregory Boyles, he founded Hometown Industries, which is the largest gang diversion and help program in the world. And he had CLL. And in the interview, he was asked, how does your CLL play into what you do? And he essentially said he ignored it because he had much bigger issues to deal with. And I think a lot of us felt very similarly. But COVID has turned that on its head for many of us. We used to get by just kind of avoiding sick friends and relatives. We were maybe a little more careful about hand washing. But now we feel threatened all the time when we step outside, when we're in a crowded setting, if somebody sneezes. Everything has been changed by the pandemic. And why is that? The numbers support our worries. 44% of those who are hospitalized for breakthrough infections, and what breakthrough infections means here is somebody who's been vaccinated but still gets COVID. 44% of those happen in the immunocompromised, while that only makes up 2.7% of the population. The rate of breakthrough infections among vaccinated folks is less than 1%. The population of those who get sick with COVID is highly enriched for those who are immunocompromised. The odds are against us. And it doesn't stop there with just getting the infection. We're more likely to get severely ill. We're more likely to have prolonged COVID, which with prolonged viral shedding, spreading it to other people. This next point is somewhat controversial because some recent data suggest that these mutation issues in long COVID carriers may be less of a concern. All the studies show that we have lower antibody responses to the different infections and to the vaccines. Dr. Mustafa will go over that in more detail. And sadly, we have a much higher rate of not surviving COVID. It used to be closer to 30%. Now it's closer to 10%. One of the questions that we get asked often at CLL Society is, should we get antibody testing after being vaccinated? So let's look at the CDC guidelines. And what they point out is that the use of these tests have not been established to show much benefit. There's no correlation between if you have this level, you're okay, and if you have that level, you're not okay. What provides protection is unsure. The tests vary from company to company and method to method. So outside of a research setting, and there's a lot of good research going on looking at this, and many are aware of the LLS trial, it's not generally recommended, but we understand if people want to know that information and think it might benefit them in terms of their choices. We just say, understand that no level guarantees protection or lack of protection. What I do want to spend a minute on is talking about a somewhat complicated issue, and that's passive versus active immunity. Immunization is a form of active immunity, and active immunity involves a complicated set of handoffs between the B cells, the liquid immune system, the antibody system, and the T cells, the cellular system. CLL patients fumble the ball a lot in those transitions. We are not very good with our active immune response, and that's not just the COVID vaccine, but that's to the shingles vaccine, that's to the pneumonia vaccine, that's to a lot of vaccines. So while in most cases, the old maxim is that it's better to teach someone to fish than hand them cooked fish or sushi if you prefer, that doesn't work for us because we may never learn how to fish on our own and we may end up going hungry. But fortunately, now there are a few good sources of prepared fish, or sushi if you prefer, in the form of monoclonal antibodies. These are pre-made antibodies. This is a passive immunity where we're given somebody else's antibodies that have been cloned over and over again, and these will passively protect us. All you need to do is be infused with them or injected with them, and they start to work immediately until they are all fade away or used up. So this is passive immunity, doesn't call on our immune system to do very much. When can monoclonal antibodies be helpful? Well, the answer is just about any time. Where they're mostly used is people who test positive for COVID as an outpatient and the disease is mild to moderate. They're also available and approved, at least some of them, for those who've been exposed to COVID but have not yet tested positive. This is called post-exposure prophylaxis, or PEP. But what's coming real soon and may even be here by the time we air this presentation is pre-exposure prophylaxis, or PrEP. Experimentally, they're also looking at monoclonal antibodies in severe cases where the patient is not making their own antibodies. This is still an experimental option. I want to finish with an analogy that some of you have heard of, but some may be new to others. And that is this sort of Swiss cheese layered approach to COVID protection. And essentially what it says is that there's no one single intervention that is going to solve COVID. So let's start, if you physically distance yourself, that's going to lower your risk of getting COVID because that's going to eliminate most of the droplet infection, but the aerosol still may travel. So you put a mask on. And if it's a well-fitting KN95 or N95 mask, that may add another 95% of protection. Now you're going to be careful about hand washing. You're going to be in a well-ventilated setting. You're not going to touch your face. All of these things are going to continue to lower your risk. And now we can add in vaccines, and even if they don't work fully, they may provide some level of protection. If we start to add in monoclonal antibodies and antivirals and better therapies, the level of risk becomes smaller and smaller, and at some point will be an acceptable risk. Each one of us has to make a decision about what level of risk they're willing to take. But overall, I have to say that the future during this pandemic and what will soon turn into an ongoing endemic kind of situation is looking much safer for all of us. Next up is Dr. Mustafa, who's going to talk about the immune system in more detail and monoclonal antibodies specifically.
Well, thank you for having me and for discussing this important and timely topic of monoclonal antibodies for COVID-19 and CLL. The talk today, you can't really talk about monoclonal antibodies without talking about immunodeficiency. So there'll be a small background on immunodeficiency and a proposed evaluation for immunodeficiency. Individuals with CLL do have glitches in their immune system. So we'll kind of talk about how to tease this out, and then we'll end the talk with therapeutic options for COVID-19. I don't usually show studies from 1973 in my talks, but I wanted to show this one in particular. This is an old study that shows that individuals with multiple myeloma, which is a blood cancer, and CLL, which is another blood cancer, compared to individuals with heart disease, their risk for infection is significantly greater than their peer group. So this is something we've known for a long period of time, that the risk for infection in CLL and blood cancers is significantly elevated. And this is a significant reason for morbidity and mortality in CLL. So this is not a new concept. We've known this for decades and decades. And not only is infection increased in CLL, this risk becomes more pronounced with increasing age. Less than 50 is, as I get older, my concept of age changes. So less than 50 is young to me now. But even here, you see individuals with CLL and myeloma have a higher risk for infection than individuals with heart disease. And as you get older, over 70, this becomes more and more pronounced. So the risk for infection is something we've known about for many years, and we need to address it. So why are individuals with CLL at risk for infection? There's different parts of the immune system, and there are glitches in individuals with CLL, all individuals with CLL. One part of the immune system is complement proteins. These are proteins in your blood that help fight infection very early on. This is a relatively small part of the immune system, but certainly an important part. Neutrophils and phagocytes are cells that will fight and help fight things like keep you from getting abscesses. T cells are an important part of the immune system. They're kind of classically help you fight viral infections. Individuals with HIV have abnormal T cells. And then really the best defined part and maybe the biggest part of your immune system is your antibody system. And as you see, the fonts are meant to kind of describe the relevance that these play. So certainly in CLL, we have abnormalities in antibodies, but also T cells. These things all work together to give you an intact immune system. So if we're talking about antibodies, what would be a proposed immune evaluation? And this is something you certainly want to discuss with your hematologist, oncologist, or an immunologist if you see them. An antibody level is a nice place to start, right? And the typical antibodies that we check for are IgG, IgM, and IgA. I would advocate that these should be tested at the time of diagnosis and then potentially throughout the illness, or certainly if there's changes in the course of the illness, like infections. Your antibody level is the size of your army. It doesn't really tell you much about the function. You might have normal levels of IgG or IgM, but it may not work that well. So what's really important to figure out the function is something we call vaccine responses. And this is something that immunologists do quite routinely to evaluate the immune system. This is done much less commonly by our hematology oncology colleagues. And this is something that I think we have an opportunity to work together and have a more directed approach, a more uniform approach across regions globally. So vaccine responses not only tell you about the level of your antibody, but they tell you about the function. And simply, you check a level of an antibody, you give someone a vaccine, and what should happen to the antibody level after vaccination, it should increase. And we all know this in the setting of COVID, which we'll talk about. But I think this is a very, very important part to evaluate your antibody function, because the level is just not good enough. The vaccine response really tells you how things are working. And then there's certainly other parts of the immune system. We talked about T cells and lymphocyte subsets, this and that. And these are important features, but I think maybe the biggest here is vaccine responses. So sometimes people question, this person has CLL, it's early in disease, they're in watch and wait, they're not having infections. Why do I want to even check these things? Why does it matter? It might show you that there are, there is immune dysfunction earlier in disease, which many individuals have. But the other thing it does is it helps with prognosis. This is a study that shows that your levels of your antibodies, if they're lower, you tend to have worse prognosis. So certainly when someone is diagnosed with any malignancy, cancer, CLL, one of the first questions is, doc, what's my prognosis? And antibody levels may even help with that, with lower levels portraying to poorer prognosis. So I think there's multiple uses for checking these things, and I would advocate that most individuals have this information sooner than later. So currently we're talking about people with CLL certainly have antibody dysfunction. So what is the current state? I told you infection is actually the most common cause of death in individuals with CLL. We know this. We also know what the most common infection is. It's pneumonia. We also know the most common bug to cause pneumonia, which is Streptococcus pneumoniae. And so how are we preventing people from dying of strep pneumonia and pneumonia? We're vaccinating them. Yet, infection remains our biggest problem. This is what's happening right now. So vaccination is clearly not really helping because it remains the number one cause. And why is that? We know that vaccines build antibodies. We talked about that just a second ago. What makes antibodies? The part of our immune system that makes antibodies is B cells. Unfortunately, CLL is a B cell cancer. So you have abnormal B cells that aren't working. So unfortunately, and not surprisingly, patients with CLL, which is a B cell cancer, don't build antibodies as we would expect because they come from B cells. And this has been shown in multiple studies. I just picked one. There's many of these. These are 30 individuals who are vaccinated against pneumonia. You guys have been vaccinated against pneumovax potentially, Haemophilus influenza, and tetanus. These are common vaccines, right? This is your pre-vaccine levels for these 30 individuals. And I told you after you get vaccinated, your vaccine levels should shoot up. Check out these levels for pneumovax, pneumonia, polysaccharide, PBV23. The levels aren't really budging. So these individuals, these 30 individuals with CLL aren't responding to this vaccine. For H flu, some of these individuals did, a few, but many didn't. Tetanus, really immunogenic, easy to respond to this vaccine. Many people with CLL did not respond to vaccination. So even though vaccination is our number one strategy and it's recommended for everyone, and I fully recommend it to everyone with CLL or any blood cancer, the responses might be suboptimal, especially with the antibody levels. Maybe there are other parts of the immune system that are responding, like T cells, but the predominant antibody response is certainly suboptimal. We know this. And unfortunately, this translates right to COVID-19. This was a recently published study of the vaccine response in individuals with various blood cancers, Hodgkin's lymphoma, non-Hodgkin's lymphoma, multiple myeloma, and CLL. And what this first graph here shows is what percentage of individuals with these conditions went from undetectable antibodies to detectable antibodies against COVID-19. And unfortunately, compared to normal controls where that happens 99% of the time, look at the level for CLL. Only about half of patients demonstrated an antibody response, which is actually the worst of all the blood cancers. So again, we know that antibodies are lower, or antibody function is suboptimal, and this is kind of rearing its ugly head with COVID-19 as well. So not only did individuals only mount levels half the time, mount detectable levels, when they mounted levels, they had detectable levels. Of those, the amount of antibodies was lower in CLL than compared to others. So many didn't mount an antibody response at all, and the ones who did had lower levels than normal controls. So are there ways to predict individuals with blood cancers who might not respond to COVID vaccines? If your level of globulin is lower, you had a less likely chance to respond. This is a level that could be checked on basic blood work. If your LDH or your neutrophil count was lower or your LDH was higher, your likelihood of responding to the vaccine was lower. So these are some predictors of response to COVID-19 vaccine in individuals with blood cancer. But unfortunately here, we see the individuals with CLL seroconverted least often, about half the time. And when they did, their levels were lower than other individuals. So let's talk specifically about CLL. This is another recently published study of all individuals with CLL, no other blood cancers. These are healthy controls. So you see what their antibody level did with the Pfizer mRNA vaccine. The fire levels for almost every healthy control bounced way up above this cutoff. Unfortunately for CLL patients, less than half responded in the study to the Pfizer mRNA vaccine, and many who responded very low levels. Very few percentage responded to a level compared to healthy control. So again, specific to CLL, vaccines their response to vaccines in individuals with CLL remains suboptimal, and unfortunately, this applies to the Pfizer COVID vaccine as well. So again, fully recommend vaccination for everyone, but we have to appreciate that the antibody response would be low. And these are graphs, again, showing that the response in seroconversion and the level is lower in CLL. This study shows that there are some differences in individuals with CLL, but unfortunately, whether you're on therapy or not on therapy, your levels remain suboptimal, even if you're in remission, and the type of therapy doesn't matter. So part of the problem is individuals with CLL have inherent abnormalities in their immune system, decreasing their antibody levels. Some of the therapies may compound that, some of the chemotherapies. But again, all individuals are at risk. So we were giving people 2 doses of the mRNA vaccine. So then it became this question of the third dose or the booster dose. And where this came from, particularly important in individuals with immune dysfunction or CLL, is this study from Solid Oregon. Many people did not respond to the first 2 doses, but did respond to the third. So I think this certainly remains true for CLL. We're hoping these studies haven't been done, particularly in CLL, but if you take this information from Solid Oregon and take it to CLL, we're hoping in those previous slides where two doses did not mount an immune response, a third or maybe even a fourth will. So vaccination remains our #1 strategy, but we have to appreciate in individuals with CLL, it may be suboptimal. Not effective, but less effective than we would like. And that's where this concept of monoclonal antibodies comes in. So monoclonal antibody is actually an antibody that's kind of manufactured against certain targets. And we've all talked about COVID-19 now for 18 months and the spike protein, and how the spike protein connects to human cells through this ACE2 receptor. So we want monoclonal antibodies that are manufactured against the spike protein. Currently, there's 3 on the market. These 3 names that are difficult to pronounce. One is by Regeneron. This probably has the most press. One is by Eli Lilly, and one is by GSK. So these are the 3 on the market right now. And what did these studies show? And there's multiple studies. What treatment with monoclonal, this is once you have COVID. So you're not trying to prevent at this moment. So at this moment, you have someone infected with COVID. And if they're treated with a monoclonal antibody, what the studies show is treatment will decrease the viral load faster than if you're supposed to clear it on your own. So viral load goes down faster. Individuals who are treated with these monoclonal antibodies once they have COVID, they feel better faster. The duration of illness is shortened. Here's the most important one. They are at a lower risk for progressing to severe illness. So you have a decreased rate of hospitalization. And the beauty here is these are very, very well tolerated interventions with very few side effects, really no different than placebo. So it's nice to feel better faster, but the key is we really want to keep individuals out of the hospital and from getting really sick. And these monoclonal antibodies seem to stop the progression to severe disease, and certainly in an immune compromised individual who may not have had a full response to their vaccine, this is a huge benefit. So who's eligible for these monoclonal antibodies? You have to have mild to moderate COVID in adults 12 years and older, and who are at high risk for progressing to severe infection, which certainly anyone with a cancer or blood cancer is. The bar for being eligible is quite low. We really do think these monoclonal antibodies are safe and effective. So, we're treating a lot of individuals with this. Any chronic illnesses that put you at increased risk, elevated body mass index, so being overweight, these are all eligibility reasons, but certainly individuals with CLL are eligible for these monoclonal antibodies. You can't use it once someone is already hospitalized or hypoxic if their oxygen levels are low, because that means you've kind of missed that window. The person's already progressed to moderate to severe illness, so it may not be that beneficial. So you really do want to treat early with these. So this is for treatment. But what we realized in the studies is, and this was first shown in this big study just published, I think 6 weeks ago, is maybe we shouldn't just treat, but maybe it may be an opportunity to prophylax or prevent. So if there are individuals, particularly who may not respond to the vaccine as well, a treatment with a similar monoclonal antibody would not only treat COVID if they have it, but it may be prevention for developing COVID. But I think this is a very, very, very exciting prospect in managing this crazy pandemic, and particularly in individuals with blood cancers and CLL who may not be responding to the vaccine like we want, who may be at increased risk for infection still, despite being fully vaccinated. This treatment with this monoclonal antibody may actually give them protection that they weren't able to mount with their vaccine. So there's a couple of trials going on that have completed now that these drugs are being looked at to be used for prevention. And this is one, and this is another product. These are single doses, and then you have protection for between 6 and 12 months. So essentially, like a diabetic doesn't make insulin, these monoclonal antibodies are giving you the antibody that potentially you weren't able to make from vaccination because you have abnormalities in your immune system. So these are very, very promising, decreasing risk of infection, decreasing risk of hospitalization. The beauty is they're a single dose with long-lasting effects. It's not something you have to do very, very often. So there's a lot of exciting work being done with monoclonal antibodies, which started with treatment, but now we might be looking at prevention. Not quite available yet for prevention, but very, very exciting, and hopefully we'll have some more options in our arsenal in the next couple of months. So we know this, that individuals with CLL have some immune dysfunction, and infections remain a big cause of complications and death in CLL. Unfortunately, COVID-19 has added to the list of infections that put people with CLL at risk. Vaccines are absolutely recommended. Everyone with CLL, everyone I think who is eligible should be vaccinated with at least, for CLL, 3 doses for sure, maybe 4. But we do know that vaccine responses are suboptimal, and this is information we've known for a long time. So this pandemic continues to pose increased risk to individuals with CLL despite vaccination. And in that setting, you want to be aware of, if you do get COVID, that there are therapies that are available, well tolerated and safe. Or even if you don't have COVID and you potentially haven't mounted a response to your vaccine, these therapies now may be looked at for prevention, which is very exciting, not quite ready yet. That's being evaluated for how to roll that out, but I'm hoping it becomes available in the next couple of months potentially. And with that, I want to thank you for your time, attention. I look forward to the question and answer session. And I'd like to transition to our next speaker, Robyn Brumble with the CLL Society.
Hello, everyone. I'm going to review CLL Society's COVID-19 action plan with you today. Many of you in our patient community were reaching out to CLL Society after either known exposure to COVID-19 or receiving a positive test result. Some even voiced that they weren't sure what to do and asked if there was anything that they could have done differently or done something to be more prepared. As a result, CLL Society decided to put together a COVID-19 action plan, which is comprised of several checklists that you can begin to fill out right now before COVID-19 impacts your home. We highly recommend that you spend some time reading through the directions, filling in the blanks as they apply to your specific situation. Print out these completed checklists and keep your personalized plan in an easily accessible place where you can refer back to it should you ever need it. I'm going to go through the 5 pieces of the plan and provide some screenshots very briefly. The first 2 pieces include reading through the step-by-step directions for completing the plan, and then filling out the corresponding checklist called Complete Prior to Exposure. The intent of these 2 documents is to guide you through what exactly you need to do far in advance of getting COVID-19. Some important things that these first 2 checklists will walk you through include looking up important phone numbers you might need to call ahead of time, having them in one centralized place, keeping a suggested list of supplies readily available, such as a pulse oximeter and a thermometer, for example, and how to find where exactly you're going to go to receive both testing and monoclonal antibody therapy. Please note, if you don't know off the top of your head exactly where you can immediately obtain monoclonal antibody therapy, within the directions, there's a link provided on item number 5 that will help you find the location nearest you. You simply click on that link, enter your zip code, and then a list of locations will appear that you can choose from. The next 2 checklists include what to do if you have known exposure to COVID-19 or a positive test result. These 2 documents will guide you through exactly when you should obtain a COVID-19 test after known exposure, how long to be monitoring for symptoms after exposure, and perhaps most importantly, how to adequately quarantine. If you aren't sure what steps you should take to try to keep from getting COVID-19, especially if someone else in your home has already tested positive, then this is a very valuable tool that you can use. Please read through this checklist so you can be well informed and be prepared. The last checklist I'm going to be sharing with you today is perhaps the most important because it tells you exactly what things to do after testing positive for COVID-19, which for some can be a very stressful time. This checklist reminds you of the steps to take early on, one of which is to call your healthcare provider immediately to discuss how you can receive monoclonal antibody therapy as soon as possible. It will also prompt you to keep a log of your vital signs and your symptoms, what to remember to do just in case you need to seek emergency medical care, and steps to take after your illness has run its course. You can find all of these checklists on our website at cllsociety.org. As you can see in the screenshot of our website, there is a COVID-19 update button located near the top of the page in red. And if you click on that button from the homepage, it will take you to our dedicated COVID-19 information page. Then in the middle top of the COVID-19 page, you will see a large icon that says COVID-19 Action Plan. After clicking on the action plan, you will find all of those checklists that I have reviewed with you today. So please remember, the COVID-19 Action Plan is there for you on our website whenever you need it. But we highly recommend that you access it ahead of time before you are exposed and before you start feeling ill. Doing so will help you have peace of mind, knowing exactly who to call, what to have on hand, and what to do in the moment. After you complete your plan, again, we suggest you keep your checklists in a folder, place them in an easily accessible place. It's also very important to discuss your plan with others in your household so they too can know what to expect. And please remember, if you have known exposure, any symptoms or a positive test result, act fast. Even if you don't yet have symptoms, call your healthcare provider right away because obtaining early treatment, such as monoclonal antibodies, are very important for achieving the best outcome possible, especially for those with CLL. Thank you, and please stay safe.
Well, I learned a lot from Dr. Mustafa and Robyn, and I hope that was worthwhile. Those are really informative presentations. We have over 100 questions. Obviously, we're not going to get through 100 questions, but we'll do our best. And just a couple things to start for you, Robyn. Remind us, people are asking, where do they get this action plan, those sheets? Can you just walk us through that again if people want to have that?
Sure, Brian. So the plan is on the website, as was just outlined in my talk. Go to cllsociety.org, and there is a large COVID-19 button at the top of the screen. And if you click on that COVID-19 button, then you will be taken to our COVID-19 page, which has the action plan at the very top. And when you click on that action plan, it will take you through all of the steps, different steps based on the phase that you are planning for.
And here's one for both Dr. Mustafa and Robyn. This is all great if you can get the antibodies, but aren't there issues? And maybe Robyn, you want to start with that? Aren't there difficulties in getting them in certain communities? And do you have any advice on that?
Sure, yeah. So again, I would first start by going to the link on our COVID-19 page for the action plan. And I would like to clarify, within the instruction piece of that plan, there is a link where you can enter your current zip code, and it will tell you the location nearest you within, I think you can set it for a 25 or 50-mile radius that are actually offering the COVID-19 monoclonal antibody infusions. So that being said, there's additional steps that we're now encouraging everyone to take. So we actually think that based on the supply problems right now, you should actually call ahead to the location you identify that might be one that you're considering, and ask them if they have any in supply and are still offering them. And this is because we have heard anecdotally from our community just recently that when people are calling to try to get them, that there have been some supply chain issues at the sites where they were previously offered. And please just don't expect that the first place you call is going to have it. Don't get frustrated. Keep on calling. It's more convenient, obviously, to get monoclonal antibodies in an infusion center, but several of these have stopped doing them. So you might have to go to a hospital, and worst case scenario, if you can't find them, you might have to go to an ER. But we just encourage you to call ahead first, be in communication with your physician. And the whole point of saying all of that is that we just want you to do the planning, walk through the process. And if you have to make 12 phone calls, it's better to do it ahead of time than it is to do it in the moment when you think you either had known exposure or you have tested positive.
I would just say from personal experience that a patient who reached out to me who was concerned that he was exposed to COVID. It turned out he wasn't. And so I started this process, and it wasn't until the 12th call that I found a place. And that was using the government. So it's not up to date. And all these dialysis and infusion centers were all hot doing it a couple months ago, but they're not now. Dr. Mustafa, I guess it varies from state to state and different situations. What's your advice or experience with patients on this?
Yeah, I echo everyone's sentiments. It's going to vary a lot depending on where people live. Regionally, depending on COVID numbers, if there's higher numbers in certain areas, it's going to be more difficult, and supply as well. I want to remain optimistic. We'll hopefully have multiple therapeutic options in the relatively near future, which may give us, more options. I mean, people have heard, we talked about the AstraZeneca potential product coming up, but we've heard about oral antiviral agents as well, right? So not today, but coming up in the near future, but certainly I echo what Robyn said, particularly reach out as soon as you know to your provider and then kind of start that process from there. Use the CLL Society webpage, which is an amazing resource.
So we talked about different options that we have, and one of the tools that the immunologists have had in their toolkit for a long time is IVIG. Can you explain to us what IVIG is? There's a new way to get it subcutaneously and how that's different than a monoclonal antibody, so patients can understand where one might help and another might help. And I'll even add a different twist to that, convalescent plasma, which is something. So can you talk about those 3 different products and how they're different and what their roles might be?
Yeah, so immune globulin is giving individuals who don't make sufficient antibodies. Diabetics don't make insulin, we give it to them. So immune globulin we give to individuals who don't make antibodies. And there are a lot of primary immune problems, fairly rare, that we take care of as immunologists. Immune problems secondary to other causes such as CLL and cancers, blood cancers, are much more common. And we talked about the antibody dysfunction, the problem with antibody production in these individuals. So some individuals with CLL and other B-cell cancers would be appropriate for immune globulin replacement, which is giving antibodies that are collected at plasma centers nationally. Doses can vary. IV is an infusion, generally takes 3 or 4 hours, given generally every 3 to 4 weeks. There's different ways to do it. There's subcutaneous, almost like an insulin pump that individuals can do at home. Dosing can go from every day or 2, shorter time period. Typically it's once a week, but there's a lot of flexibility, tons of patient autonomy. It's important to note that IV or sub-Q, no matter how you deliver the immune globulin, the antibodies, they're equally essentially effective. I will say the sub-Q route tends to have less side effects. So in some people's eyes, including mine, I think it may be the preferable delivery choice. And it also gives patients tremendous autonomy. It can be done at home. It can be done on your own schedule. It doesn't need to be done in an infusion center. In the setting of COVID, I think it's very important when you get plasma donations from lots of individuals and then you get their antibodies, you have a very diverse antibody repertoire. And I will say, we don't know details, we don't know levels, but individuals who are already appropriately on immune globulin replacement, we are starting to see COVID antibodies mixed into these commercial products. This is not a treatment or a prevention for COVID to go on immune globulin replacement. No one's saying that. But if someone is appropriately already being treated with that, there is going to be increasing COVID antibodies in the commercial products because it's coming from donors. And there is a delay from the time someone donates plasma to the time it gets in the product. It's 6 to 12 months. So people who are getting immune globulin today, their donors gave it, up to a year ago. So as we go on, we're going to see higher and higher levels of this. So that's something to be aware of. And again, another way of protection. The last thing Brian mentioned was convalescent plasma. That has been studied for treatment of COVID, active COVID infection. The studies have not been hugely promising with great results. So this is not something that's being routinely done right now. It's, again, another way to give antibodies in a different setting. But immune globulin replacement is something many of you may be familiar with. It is another way, the Swiss cheese model, many ways, right? There's not one way to do this, many strategies. It is one. But again, I want to emphasize that's something you want to work with your oncologist, your immunologist. It is not, the reason to go on that therapy is not just directed at COVID, but more so global antibody problems and infection problems.
Couple follow-up questions on that. Can you, if you're already on IVIG and you test positive for COVID or you've been exposed to COVID, can you get on the monoclonal antibodies? Can you have both?
Yes, you can absolutely have both. And there's really no contraindication. There's no reason someone who has active COVID, who's at risk for progression, PCR positive within 10 days, there's really no contraindication to that individual being treated with a monoclonal antibody. Recent vaccination is not one, IVIG or sub-Q IG or any other therapies. None of these are reasons not to. In fact, most of them are probably more reasons to get it.
We don't know yet because we're just very early into this, but we're looking like we may have some active antivirals. Do you have a sense of how these will play out, how the monoclonal antibodies will use the antivirals? Will they be used in combinations? I know I'm asking you to speculate here because this is brand new. I mean, we just got approval of the Merck a drug yesterday, and the Pfizer drug is waiting, and hopefully it'll be approved or authorized soon, I should say, not approved. Any thoughts on this? You must be thinking about this as a clinician and with vulnerable patients. Yeah.
Sure, great question, Brian. Again, options are nice, right? And right now we're limited to a therapy that's generally an infusion. And that's logistically difficult, and that's part of the problem with the available supply and patient access to this. So it will be great to have additional options, whether they're subcutaneous options or certainly oral options, right? This is something that we're looking forward to. My guess is there's going to be a role for all of these therapies going forward. It's not going to be one over the other or just one of them. I think there's going to be a role for all of them. And, the right situation for which one, we have a lot to learn. It's hard for me to say right now. I will say the monoclonal antibody infusions that we're using right now, I think have been shown to be highly effective in preventing progression to severe disease. And I'm not sure that oral antivirals will meet that similar bar. But again, there may be a different role for different therapies in different populations. But I'm excited to have additional therapeutic options. Certainly, one would imagine with an oral antiviral, access should be better, easier, right? Not as complicated. So I look forward to having that, to learn about it and to figure out who to use, who to treat with what eventually. But it's certainly something we're eagerly anticipating.
Just to clarify, I'm asking a lot of questions on the monoclonal antibodies, but that's what we're talking about. Are these blood products? Is there blood in these, like there is an IVIG, which are, collected blood products? Convalescent plasma, by its name, is a blood product. Are these just help patients understand whether this is a blood product or not?
Yeah, so it's generally not. No, immune globulin is certainly a plasma product, so donated from other individuals. And again, it's a scarce resource. I've been in practice about 12 years, and there have been 2 episodes in my 12-year career where we've had a nationwide shortage. So it is based on donation. Monoclonal antibodies are recombinant IgG. My presentation mentioned IgG is one of your big antibodies. And this is recombinant kind of synthesized IgG, so not quite the same. That's an important differentiation.
And they may have started with someone who fought off a infection in Wuhan, and then they've cloned that antibody. They may have used that as a prototype, but it's been cloned. It's not from that person anymore at this point. It's been cloned millions and millions of times. A couple other things. Talk to us a little bit about vaccines and monoclonal antibodies. Is there timing? There are people, I just talked to a friend in New York who was exposed, got monoclonal antibodies. She was told to wait 90 days for vaccination. But I don't know that there's a lot of science behind that. I think it was just people saying, makes sense. Do you know anything on that?
Yeah, so I think the most important thing is please, 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 if you haven't been vaccinated, get vaccinated. That's easy. That's one of the things we can say. I don't have much, I know for sure, but I know for sure you should be vaccinated, and you should at least be vaccinated with 3 mRNA vaccines at this point. Even if your response is suboptimal, even if your antibody levels are undetectable, there are other parts of your immune system that we talked about that we are not very good at measuring. So I would say there's no such thing as no response to the vaccine. There are certainly, unfortunately, suboptimal responses, but that's still step 1. Being treated with a monoclonal antibody, again, there's no reason not to be if you have COVID, PCR positive, or early in illness within the first 10 days and are not sick or requiring oxygen. So it doesn't matter when you were vaccinated. It doesn't matter when you had your last round of chemotherapy. You can be treated. Once you are treated with a monoclonal antibody for COVID, the recommendation is to wait 90 days until you're vaccinated if you have future vaccination against COVID. And that's because these antibodies kind of surround and suck up, right, COVID virus. So if you start to build your own antibodies to a vaccine, ideally, these antibodies might neutralize it. So you do have protection. And we, the Regeneron IV product that we're using, and I showed that slide too. We're using it for treatment, but it's becoming clear that it provides somewhat prolonged protection from future infection. And now we're talking about pre-exposure prophylaxis. So these are really effective therapies that aren't just going to treat you in the moment. They will give you some protection in the future. So being treated with the monoclonals, no wait, you do it when you have to. If you do get treated, the only thing that I would delay is COVID vaccination if you haven't already had it. And I hope most of this group has. But beyond that, it wouldn't affect any other therapeutics, chemotherapy regimens or anything.
And what I've seen, at least on 2 of the products, is in non-human primate data, the antibodies have not affected the response to the vaccines. So in theory it does, but it seems, at least in non-human primates, it doesn't. I don't know if there's been human data on that yet. There's the pre-exposure to be practical needs to be of a fairly lengthy duration. So we've had some recent data that suggests that the RegenCov might be longer acting than was originally authorized for, 2 to 8 months. I've seen, and the AstraZeneca product, the AZD7442, was designed to be longer acting. It's intramuscular. It's 2 shots in the gluteus, and it's 6 to 12 months. Do we know anything about the other 2 and their length of action? And is this a direction that you think we'll be seeing, this pre-exposure prophylaxis every 3 or 6 months, or maybe even once a year? What do you, in your crystal ball, do you have a sense of where this is going to be going for the people who don't respond to vaccines?
Yeah, so this is really fascinating. Typically IgG, which is what these things are synthesized to be, these monoclonal antibodies, typically the half-life is about 3 weeks, 23 days. So every 3 weeks, half of it goes away. So you lose effectiveness, pretty quickly after a month or so. And that's why anyone who's on IV IG typically gets it every 3 to 4 weeks. The science here with these and the longer lasting antibodies is fascinating, and a huge part, because it's not practical to get these necessarily every month or so. The long lasting duration is key and actually really exciting, and one of the huge benefits of these potential therapeutic options. Brian, you're up to date more than I am even, and that's kind of the data I know on the Regeneron product is 2 to up to 8 months. And the AZ product is between 6 to 12 months from what I know. I don't have information off the top of my head on the other products right now. But certainly what we're seeing is there may be, long-lasting protection after these interventions. And again, you can't practically do it at a high frequency, but if it's once or twice a year, that's pretty incredible, but even more would be manageable, I think.
Talk to us a little bit about the tests that people can get afterwards. I touched on this a little, and it's controversial. I don't think that there's a correct answer. But what are you recommending to your patients about being tested, and after vaccination, but also after the monoclonal antibodies? There's a number of questions. Should people be tested to see if they responded? I'll tell you what I think. I think no, because you're going to respond. I mean, there's no, it's going to work because you get it. I mean, it's like you're given it. It's like, if people put the money in the bank, the money's in the bank. It's not like you have to make the money. It's there. But I'll hear your answer. Yeah.
Yeah. So as an immunologist, I've been measuring antibody levels to various things my whole career. We talked about pneumonia or tetanus or meningitis. We can similarly measure antibody levels to COVID-19. The problem is we're not sure what to make of the levels. A level of, I'm making up numbers, 100 seems better than 50, but it may not be. They both may be good enough, right? So the general recommendation is there is not a high degree of usefulness in these tests. And the other thing is there are many tests that have huge variation in quality and what they put out. Some are yes, no. They'll say, do you have antibody or not? A qualitative test. Some will give you the number. Some will try to differentiate your antibody level from vaccination versus infection. So there's a whole bunch of stuff. So it's hard to know which is the best one. In my practice, I do not generally recommend these tests to everyone I see because I don't know what to make of it and what am I going to do with the information. But in certain populations, and I will say in my CLL patients, I have ordered these tests. A negative test in my systems, I know how they run the test and I can interpret it, is disappointing. It means you probably haven't built antibodies. Like I said, there's other parts of your immune system that may have responded to the vaccine, but a negative test suggests you didn't build an antibody response. This is to the vaccine. A positive test is reassuring, but I don't know the level of the vaccine or the level of the antibodies, and I don't know how long they'll last. But it's reassuring. So in certain special populations, including CLL, I have offered the test to see if there's a vaccine response. I agree, Brian, if you are treated with a monoclonal antibody, I don't see any utility in getting the test because you have it. I mean, you were given it. There's no way you can't have it. So the test, even if it happened to be negative, which I don't think it would be, but I wouldn't believe it. So in the setting of vaccination, it's a curiosity question, I think. Eventually, hopefully, we'll have a standardized blood test to see who's responded to these COVID vaccines to an appropriate level. We're not quite there yet, like we are for other things like pneumonia. But for after monoclonal antibody, I don't think there's much utility and there's too much heterogeneity. There's too many different tests. I wouldn't even know what to make of it.
Robyn, a couple practical questions. Do you know whether people need an order to get the monoclonal antibodies, or can they just show up at a center and the doctor there will take care of it? And what about practical? If people do want to get the antibody tests done, do you have any advice on that?
Yeah, so I'll start with the easier one, I think.
Okay.
The antibody test requires an order. As far as I'm concerned, everywhere in America.
No, actually,
no, am I wrong?
No, you're wrong. You're wrong. I'm sorry. You can LabCorp, you can order. Go ahead, Robyn. Go ahead.
Go ahead.
I'm going to say LabCorp, at any LabCorp across the country, you can order your own quantitative spike protein antibody test. And all you have to do is you do have to create an online account to do that. And then you show up, make an appointment, and the cost is $10 across the board. So
okay,
you
so
don't need a doctor's orders, but you need a LabCorp near you. And I've had that done. And also LLS will do it for you. You can roll in their trial and they will do it for free and you get to see your results. And there's several other trials that are going on. So there you go. That's why I love these. I learn more than I can ever teach. So there are different access points to the testing. And again, you have to interpret. I think the results can be meaningful, but they have to be interpreted with caution. I don't think they're useless results, but I also don't think they should vastly change behavior or anything. It's a little bit hard to know what to make of them, but I think they can be meaningful and part of the puzzle in deciding how to move forward with life. As far as the monoclonal antibody therapies, I'm almost certain it depends regionally. I think certain areas, I think Florida has far more access, almost drive-in centers potentially. I don't know the details. In our area locally, it needs to be ordered by a physician. So I think there's going to be some heterogeneity depending on where you are, availability, and how they've processed it. Hot off the press, right? I think there was going to be a news conference today with the president about potentially the government being more involved in making access better for some of these therapies as well. So I think this is a hugely dynamic process. It's going to depend on where you are, and it may be different today and tomorrow versus today. But certainly I would start, what Robyn said earlier, be prepared, start with your provider, know kind of the lay of the land where you are. So, Robyn, as a nurse, do you have any thoughts about, I think I know what your answer is going to be about a booster, but what about mixing and matching vaccines? And what about getting a fourth shot? There's been talk about that in Israel. They're looking at that as an option. You're in an area where there's a significant outbreak of COVID and a lot of people are not keen on getting vaccinated. So I'm just wondering, when you're making these decisions for your friends and family and yourself, what are you looking at?
Yes, absolutely get your booster. I think the CDC and others have come out and are recommending that right now, especially with the new variant. The messaging has become stronger. As far as a fourth dose, I know that, like you said, there are some preliminary studies going on in Israel. I have not personally seen the data on any of that yet. I know that anecdotally, we have had those in our CLL Society community who have mentioned they're already receiving a fourth shot, or at least thinking about it. So that's not off the table altogether. Again, I would talk to my CLL specialist about that and get their point of view. And Brian, I don't know if you have a perspective on that as a patient as well.
Well, what I know is two things. One is that some people who don't convert with the 2 shots do with the third. It's probably about a half based on the LLS data. So it's worth doing that. So if some people convert with the third, maybe some will convert with the fourth. At some point, there's diminishing returns. But, COVID is not our friend, and the vaccines are pretty damn safe. Pardon me. They're pretty safe. So, I'm leaning more in that direction. But, this is a moving target all the time. Let me, I'm going to throw a softball question, then I'm going to ask about Omicron. I kind of left that to the end. Here's a softball question for you, Dr. Mustafa. You'll like this. So should every CLL patient, or should a lot of CLL patients, have an immunologist as part of their team? Because immunologists are not, generally part of, what that community sees. And I know that a lot of immunologists, frankly, are dealing with overactive immune systems, allergies and asthma and things like that. And so help us understand what your role is working with your hematology oncology colleagues.
Yeah, that's the opposite of a softball, Brian. That's like a gnarly knuckleball.
Oh, I'm sorry.
Swing and miss. I think this is how I see this. Cancer and CLL and all of this stuff, these are complicated conditions. And I think generally, and I grew up on the wrong side of medicine with a sister with many chronic illnesses. Generally, a multidisciplinary team is a great idea when you take care of complicated people. I love asking for help. My hematology oncology colleagues are the quarterback of taking care of individuals with B-cell cancer, including CLL. I do think that having an immunologist perspective can enhance the management and can potentially improve the management. You may have a hematology oncology colleague already familiar with the things that an immunologist may offer. I do think there's a role, again, nothing's dogma, every patient is different. There is a role for evaluating immune globulins and potentially vaccine responses. There is a role for subcutaneous. For whatever reason, immunologists use a lot of subcutaneous immune globulin, and oncologists use almost exclusively IV immune globulin. There's different reasons for that, but at the end of the day, I like to give my patients options, and you shouldn't be committed to one thing or another because of who you see. So I think a team approach is great. You're right. I mean, the practicality is that there are not that many immunologists who work in this space, and there's not that many parts of America that may have immunologists that are interested in this space. So again, lean on your hematology oncology colleagues. I think the start of every battle is awareness. And it seemed like with the poll answers that there was raising awareness during this hour. I've learned a lot myself. So start with your oncologist. Ask them questions. Has your immune system been evaluated? If there's abnormalities, what are some options? We have a lot to learn. I wish we worked together even more than we do, but I see it as an opportunity, because if we work together as colleagues, I think our patients will generally have better outcomes. I really believe that.
There's a number of questions. First, somebody made the point in that the third shot there's controversy a little bit about this, but maybe it's best not called a booster. It's part of the primary series for the immunocompromised. So point well taken. And is the fourth a booster, or is it, like kids get series of 3 shots? A number of questions on BTK inhibitors like ibrutinib, acalabrutinib, and venetoclax. Will they affect the monoclonal antibodies? No, I mean, because they're not asking anything. Will they affect your immune status? They might. Venetoclax can lower your neutrophil count, and that may make it harder to fight off an infection. The BTK inhibitors are less clear. They have some anti-inflammatory activities that might be beneficial, but they can also affect how the B cells communicate with other cells, so that might be a problem. So the picture is less clear, and that's a decision. Should you contract COVID, you have to make with your local doctor about that. Omicron, tell us about. I think I know what you're going to say, which is you don't know, but I want to hear this, and I want to hear Robyn's practical advice as a nurse. But I'll let you go first. Omicron, what does it mean in terms of vaccines for the immunocompromised, and what does it mean in terms of monoclonal antibodies? Do we know anything at this point? Is there anything we could tell people?
Yeah, here's the softball. I'll take it. We don't know much, and I think things are moving very, very quickly. And we heard about Omicron earlier this week, maybe, right? And now everyone has strong opinions. I think we have to take a quick pause. We will know a lot more in the next 1 to 2 weeks. But again, the recommendation is even stronger. Robyn alluded to this. With these variants, it's even more important to have not just 2 doses of mRNA vaccine, but 3. And there is likely protection, to some degree, even against Omicron with the 3-dose series, likely. But we have a lot to learn. The monoclonal antibodies will, again, there have been changes in uses regionally, even in the US, based on the predominant variant. Even in the US, when the Delta wave came, some were a little more effective than others based on their manufacturing process. So there may be some changes in effectiveness, not safety, but effectiveness, if Omicron becomes the predominant variant. And we still have to wait and see. So as of right now, it doesn't change anything except makes it even more important to be vaccinated to 3 doses, and still consider therapeutics when they become available. Will there be decreased effectiveness of vaccination or therapy if Omicron becomes a predominant variant, or at least a co-dominant variant with Delta? TBD, to be determined, but we'll know that over the coming weeks.
And antivirals, do you think they have a different mechanism of action? They don't really care about the mutations on the spike protein. Am I right in assuming they'll be less affected by these mutations, or is that naive?
From my understanding, I don't think they would be potentially affected by variants, because they're going to use a little bit of a different mechanism to treat the active infection. But again, I've been wrong so many times in the last 18 months. I'm going to reserve my answer until we actually have some science.
Robyn, any advice with Omicron? And let me ask you to go back to what we had even before we had vaccines: masks, social distancing, some of this stuff. Just if you could refresh us a little bit on that, because that's still part of the ball game, isn't it? Yeah.
Exactly, and that's exactly what I was going to allude to, Brian. Is that we want to get past all of this. We all do, but we also have to remain vigilant. And so going back to the basics again, I know it sounds like an old broken record sometimes, but making sure you're doing hand washing, making sure you're wearing a tightly fitted, preferably N95 mask if you have to be around crowds of other people, especially unvaccinated individuals. Preferably you won't have to be around those by choice if at all possible. Going back to making sure you're keeping your distance. Vaccination, as we have reiterated. And again, going back to that COVID-19 plan, have your plan in place, because right now we just, again, don't know what we don't know yet, and we're learning. And then last of all, just stay in tune with the CLL Society website, because as soon as we know things, or as soon as we're having the cutting edge news and data that is going to undoubtedly be coming out at us very quickly here in the next couple of weeks, we will be sure and put that out there and update everyone on what we do know.
Brian, I want
So
to add one thing to Robyn's,
please.
if that's okay. I think it's also important to note it's not always what we do and what we choose to do, but it's how we do it. There are things you can do, and if you take some appropriate risk mitigation strategies, maybe it's appropriate to do it. A lot of us can buckle down and not leave the house, or not see other loved ones for a month, 4 months, 6 months, heck, maybe even a year. Coming upon 2 years, and these are really important, meaningful. This is what makes life life, right? So I think also to be cognizant, even if you have CLL and have a suboptimal response to vaccine, it is so important. We've talked about cocooning in immunology since the beginning of time. How do we protect our most vulnerable? We vaccinate around them. So again, it's not necessarily what you do, but it's how you do it and who you're doing it with, just thoughtfully. So again, I think that's another way to think about it. I think everyone's circumstances are very unique, and we have to think about how to do some of these things that are important to us.
I apologize if I didn't get to your questions, and please send them in. We have an Ask the Expert, and you can send those questions in there. We'll try to respond to that. I'll give each Robyn and Dr. Mustafa like 30 seconds for any final comments or advice that you want to share with people. You go first, Robyn. You want to go?
Yeah, again, that Ask the Expert box is a great resource for anyone who didn't get their questions answered. And the email for that, I don't know if we put it up on the screen or not, but it's asktheexpert@cllsociety.org. Any questions that you have specific to this webinar that did not get touched upon, we will respond to. So use that as a resource. And again, stay in touch with the CLL Society website. As new information is out about the variant, we will be addressing that, and of any new therapies as well. New monoclonal antibody therapies, new oral therapies that will fight COVID-19 will be addressed at some point. So thank you for staying in touch, and thank you for this webinar today, Brian.
Dr. Mustafa, you get the last word here.
I'd just like to say, I think it's important to acknowledge this has been a really difficult, challenging time for all of us. And I think particularly individuals at higher risk, folks with CLL. We've made tremendous advances in a short period of time in medicine in 18 months, and we have a long way to go. The pandemic is unfortunately not over, but I do think there is reason for optimism. Vaccination is an incredible tool to get out of this mess, and now with upcoming therapies. So stay in touch with amazing resources like the CLL Society. Stay in touch with your provider, your trusted oncologist, whoever you trust in the medical community. Incredible amounts of misinformation floating around out there. So these are amazing resources, and we will kind of come out on the other side of this, I'm confident. And I thank you guys for having me today. I hope everyone has found the discussion helpful. I've learned a lot. Thank you.
Thank you so much, Nurse Brumble and Dr. Mustafa. This has been great. Again, I want to thank the grant support that we received from Adaptive, Pharmacyclics, Regeneron, Janssen, and Bristol Myers Squibb for making this possible. And thank you all for attending. Please fill out the post-event survey. It really helps us know what we missed, what we could do better, how we could respond better. There's the link that Robyn said. A number of people asked. This will be up usually within about a week or so, definitely within 2 weeks. It'll be up. There'll be a closed caption that will be available when it goes up. So because I know at least one person reached out about being hearing impaired, so that will be there. So, and please remember, it's the end of the year. If these kinds of things are helpful to you, the CLL Society is invested in your long life. Please invest in the long life of the CLL Society by supporting our work. There's a donate button on the website, and we appreciate that. I look forward to everybody having a blessed holiday season and a 2022 that allows us, maybe we're never going to be as safe as we were pre-COVID, but maybe we're safe enough to get back into the world a little bit. And I say that the doctors like Dr. Mustafa and the hematologist oncologists are way smarter than this virus, and we're gonna outsmart it, and we're gonna get around it. And I have tremendous confidence that our world, it's never going to be that there's no chance, but there's going to be where you're going to say, you know what, I got a 1 in 500 chance of something happening here. I think I'll fly and see my kids in Chicago or whatnot. I think people are going to start to do that. And certainly those are the kinds of things that I'm weighing and considering. And when you think about that sort of Swiss cheese analogy, I think we're getting a lot of slices of cheese in there right now. And I think we can start to begin to feel a little safer, even with Omicron. It's a little early, but you know, I'm remaining more optimistic now than I have been at just about any point in the last year and a half. So thanks everyone. Blessings for the holidays, and we'll see you in the new year. And don't forget to visit us and support us. Thank you.